PRP, the way I describe it is like candy for a baby. Imagine the eggs are babies and you're giving them candy. They're going to be super excited and happy, and they're going to function better. As long as someone is healthy to carry a pregnancy.
Okay.
And I don't give a shit, excuse my language, I don't give a shit how old she is. If she's healthy to carry a baby, she's a candidate.
What the heck is PRP, and why aren't we all offering it to our patients? Today, I'm going to share what the data actually tells us about ovarian PRP and whether it can actually help women with diminished ovarian reserve. But first, what is PRP? Platelet-rich plasma is derived from a patient's own blood. So this is a part of the blood that is concentrated with platelets that release growth factors and cytokines that are believed to promote tissue regeneration and repair. So this is an exciting concept when you think about the ovaries, because we know that women are born with all the eggs that they're ever going to have. And over time we lose eggs and our egg quality does decrease. And this is a major driver of infertility and pregnancy loss. So with ovarian PRP, people will have this platelet-rich plasma injected into their ovaries in the hopes that it will help to stimulate follicular development, even if their ovaries are dormant or have low activity because they're in menopause, improving ovarian blood flow, trying to enhance the environment, and potentially rejuvenate aging ovarian tissue by activating stem cells. That's the claim. What does the research show? Well, up until last year, the research was really limited to small observational studies, case series. I'm talking handfuls of patients and just descriptive studies saying what they did and what happened after they had the PRP, not really comparing them to a control group. And yes, there are some reports that show a bump in AMH levels or follicle counts, but there hasn't really been any definitive data to show that this actually improves what matters, live birth rates. And there is this thought that by mechanically disrupting follicles, yes, you might have a bump in your AMH because you're releasing that from some of the granulosa cells into the bloodstream, but this seems to be very transient and not a long-lasting effect. Lucky for you, over the past year in 2024, 2 randomized controlled trials were published. Now, randomized controlled trials are considered class 1 data. This is the gold standard when it comes to medical research. The first study included 60 women aged 30 to 42 who had demonstrated a poor response to IVF ovarian stimulation in a prior cycle, and they were randomized to either receive a shot of PRP or a placebo injection in their first retrieval. They went through 3 successive egg retrieval cycles, and then all of the eggs were fertilized. Here's what they found. There was a slight increase in the number of mature eggs retrieved in the PRP group. It was 10.4 on average versus 8.9 eggs retrieved in the non-PRP group. So one has to wonder how clinically relevant that actually is. No difference in the number of blastocysts that were formed that were euploid. And interestingly, the control group that did not have PRP had a significantly higher pregnancy rate of about 60% compared to the PRP group that had a lower pregnancy rate of 27%. The second study was a multi-center randomized controlled trial that included women under the age of 38 who had at least 2 retrievals in the past yielding less than 3 eggs. And they found these 83 women that were willing to participate, and 41 of them got an injection of PRP into their ovaries within a week of starting their egg retrieval cycle, and the 42 other patients didn't receive any intervention. And they found no difference in IVF outcomes among the 2 groups, no difference in the number of eggs retrieved, ovarian reserve markers, fertilization rates, even the number of blastocyst embryos that were obtained, and most importantly, no difference in pregnancy rates. Listen, as a New York City-based fertility specialist at one of the most prestigious centers in the country, I would love nothing more than to have a proven tool that's safe and effective, that is known to actually improve ovarian reserve response to treatment and IVF outcomes. But the fact is, PRP is still experimental at best. This is a treatment that is invasive, not entirely without risk, and it does cost thousands of dollars depending on where you go for it, and it's not considered standard of care. It lacks the robust evidence that is required from large-scale, well-designed, controlled trials to support its routine use, and none of our professional societies currently recommend it as a standard treatment for improving ovarian reserve or response. Until the data proves that this is effective and safe, PRP should be used primarily within research settings. And if patients do want to try it, they should be thoroughly counseled that this is experimental in nature.